Welcome, everyone. I'm Dick Deming, Medical Director of Mercy Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic this evening is sexual health, and our guest is Erin Sullivan Wagner. Welcome.
Hello. Thank you. Glad to be here.
Erin, we'll learn, is a cancer survivor, but she's also the executive director of a not-for-profit called After Cancer that helps cancer survivors, especially in this area of sexual health. So it's an area that we don't talk about enough, and that's
definitely don't talk about
exactly why
enough.
there's After Cancer.
That's right. We don't talk about it enough. When we first started this organization, we learned why we don't talk about it enough. So as a patient, I knew it wasn't addressed with me. But when I started visiting with other patients, it wasn't always that sexual health in general wasn't talked about, sexual function wasn't talked about, but none of the things that impact our sexual health, like body image or how we communicate with a partner after these changes take place, none of that was being talked about or addressed in any kind of way. So that's why we started our organization.
Yes. So, I mean, it's a necessary function for cancer centers to kill cancer cells, but that's not the only purpose or function or mission of cancer centers, and thanks to people like you, that whole role is expanding. So before we start talking about it, let's learn a little bit about you.
Okay.
Where are you from? Where'd you go to high school?
So I'm from South Dakota. I'm from Madison, South Dakota, where I went to high school at Madison High, where you
Where
went
I
to
went
high
to
school.
high school.
Which is small world story. I came to Des Moines to listen to Dr. Deming speak at an Above and Beyond event that he was giving the summary of the event and an inspirational talk. And as I was listening to him speak, he flashed on the screen that he was a jackrabbit from Brookings, South Dakota. Brookings is like next door neighbor to Madison. So I just kind of looked at him again and looked at his name tag and started texting my family. Like, do we know Richard Deming? Is he Dick Deming? Oh my God, Dick Deming. So I stayed afterwards and said, God, he lived a couple blocks from me.
And you and my sister were in the same class. Yes. So,
yes, Harriet.
So we were 5 classes apart, so weren't in the high school, but I was in high school with one of your brothers. So.
Yes.
So, yeah, very interesting. Your story, though, from Madison, South Dakota, where did you go next?
Then I came to the University of Iowa.
Yeah. And how did you come to Iowa?
Well, my sister was here.
Okay.
She had come to Iowa to go into physical therapy, and she wanted to go to a Big Ten school, and I was the little sister, so I did whatever she was doing.
Yeah.
So,
because back in the 1970s, like going all the way to the University of Iowa,
right?
I mean, that's a 6-7 hour drive,
right? I was something.
Yeah,
I was going out of state. I was leaving Madison.
And then, what was your career?
So I was in marketing. So went into sales after college and was just a sales executive for a long time until really that I started this organization.
Yeah. And then, like many people, sometimes a mountain falls out of the sky that you have to climb, and that mountain is called cancer. So
yes, and
maybe share a little bit about your cancer journey.
Yeah, so in 2008, I was diagnosed with anal cancer, and that isn't something I'd heard of before. That it was a rare cancer then. I think it probably is still considered a rare cancer. However, it's an HPV cancer. And at the time, they told me that I would have no sexual health challenges. I had chemo and radiation as my treatment, and it was 5 weeks long. And really, as a patient, when you're given a diagnosis of cancer, you're really not thinking about life after your treatment. You're getting through the treatment. It's really the only thing that's of great concern. So sexual health wasn't a concern of mine at that point anyway, but I was told I would have no sexual health issues and went through the treatment pretty well. And it was 5 weeks of chemo and radiation, and 6 weeks later they said you could just resume go back to your life. Just go back to normal. And that meant having sexual activity with my husband again. And what we learned quickly is that penetrative sex was impossible. And I went back to my oncologist, it was my medical oncologist, and said, I was told I would have no issues, but something's really wrong here because penetrative sex is impossible. And they said, well, we've never heard of that before. However, it wouldn't be us. That would have been radiation that caused it. So we'll give you a referral to radiation. And so a month later, I had a referral to radiation, and radiation said, wow, we haven't had this complaint before, but we'll give you a referral to your gynecologist. And so a month later, saw the gynecologist who did see some scarring, some web scarring in the vaginal tissues from the radiation, and gave me a referral to pelvic floor therapist and gave me dilators and estrogen cream. But in that time period where I wasn't being treated, when sexual health wasn't being addressed, it hadn't been normalized in any way, my body needed those dilators, needed that estrogen. And because I had waited 5 to 6 months, it was irreversible. So we went through treatment, through pelvic floor therapy, through all that they do to help with being able to insert the size of a penis into the vaginal opening. And it was because there was scar tissue built up around the vaginal opening that it just wasn't going to happen. So we chased those treatments for a few years, and in chasing that connection that a couple has to each other, you get lost in what's going on. It's almost like you can't see the forest through the trees. Are we okay? I just wanted to fix what was wrong so that we could be okay the way we had been okay. And in me searching for that treatment to make that okay, we kind of lost each other. And that brought up just a whole nother thing that cancer patients go through, and it's not always even about sexual health. It's just that connection that you lose to each other because it's a lonely, lonely place. Cancer is, and you're the only one experiencing it, not your partner. Not that the partner doesn't have their own experience, but it feels very alone in what I'm going through. And I'm sure he felt that way too, but we didn't discuss that. We hadn't been given any advice about we might need counseling. We needed counseling badly. But I couldn't even see that until down the road when I looked back on how did we kind of fall apart here. I thought I was working on our connection, and having it happen to me was just really quite amazing for me to see how that happened when I thought my eye was on it. And I started life coaching other patients afterwards, and it was really more about the emotional challenges patients go through. And in that, I just learned how common this is. And it really isn't about sexual function. It's just about the connection that people have to each other. It's that intimacy. It's all about sexual health and well-being.
And as you are exploring what's wrong with the fibrosis, the changes in the anatomy that made penetration impossible, were you also, you and your husband, exploring counseling, couples counseling?
No. And, in hindsight, what the heck was I thinking? In hindsight.
Well, there's two of you.
Right. 4 kids, lots of activities, junior high, into high school. We were focused on the everyday activities that we're all focused on. We had dinner together every night, and we slept together, and we went to all the kids' activities together. But we had lost all intimacy with each other. We definitely had lost our connection to each other. And it's hard to believe, really, because you couldn't have penetrative sex. That happened. it's hard to believe that's true until you get inside the complexity of relationships. And it wasn't difficult for me to see how it had eroded. And it was not paying attention to that part of our relationship. So what happens when you know you're not going to have penetrative sex, and if you were used to having penetrative sex before you went to sleep at night, what you notice is that you do some of your rituals change that lead to that. So you don't cuddle in bed for the hour before you go to sleep. You call your mother instead. You don't go on those weekend vacations. You don't make flirty comments. You don't kiss deeply when you know it leads to something that's going to be so disappointing and frustrating. And that is one thing that I noticed about him. But again, it was all in hindsight that I was able to kind of put it together. But I did notice that he had gone from just not wanting to hurt me. You can imagine being the person that's the source of the pain, and me not being able to cover up how painful, at one I thought I would pass out. The pain was so great in attempting to have penetrative sex. He was disappointed, of course. He was more concerned about me, but he was disappointed and he was frustrated, and then he was silent. And the silence, I think, is where I didn't see that we could probably use some help. It's obvious to me now, and it's obvious to me when other couples talk about it, that talk therapy between two people is so healthy when you don't have any sexual health issues between you. But we didn't at the time, and nobody gave that advice. And I could just see that I'm pretty typical, I think. This must be what patients go through. I was treated at a NCI-designated cancer center, a comprehensive cancer center. There was just no reason that somebody would say, wow, I've never heard of this before. Either I'm a freak of nature, or you're possibly not asking your patients about something that impacts their quality of life.
Mm-hmm. Yeah, it is just hard to imagine providers in medical oncology, radiation oncology, actually saying they've never seen it before. And clearly what they really are saying is that they've never asked about it.
Right.
And patients haven't volunteered, but it's such it's universal. 100% of patients that went through what you went through would have those sort of side effects.
Correct.
100%,
Right.
not rare. But obviously, you were not a medical person. You probably got enough training to be an MD through your own cancer journey, as many people and families do. Mm-hmm. But it was really this being just absolutely dumbfounded that these highly professional cancer doctors at an NCI-designated cancer center would say these things to you and indicate that they have no knowledge about not only how to ask about it, but how to adequately address the problem. That you, being a doer and a coach, took it in your own hands to say, well, if you really don't know about this, how many other medical professionals don't know about this? And it's important to us as patients to have you know about this.
So what led to that, you're right in what you're saying. What brought that to a head was at one of the appointments, one of the last appointments after we tried everything. They were coming, lidocaine and something to protect the skin and different kinds of dilators, and they prescribed an anti-anxiety drug. So they prescribed Xanax to me, and my husband was there and wanted me to take that 45 minutes before we attempted to have penetrative sex. And when we left the appointment, my husband said, "Do you think that they think this is in your head?" And I said, I don't know. Do you think that this is in my head? And he said, I wonder. They've never heard of it. No other patients have had this problem. They've thrown every treatment they can at it. Really? You're the only person? And I think that, because I was so upset about that, I thought I could be that voice to say, I'm not the only person that this has happened to. How dare you not know that this is important to your patients, especially because we are curing cancer. I mean, so much about our advancements in treatment and the technology really is curing cancer. And so you're left with these long-lasting side effects that cancer causes. It seems unacceptable that you wouldn't care about that part of my life, care about all of me.
Mm-hmm. And so as a result, you have created what is now a not-for-profit,
Yes.
Aftercare. How did you, I mean, I can understand your motives and your objectives, but how did you then take it upon yourself to actually do this work of creating training for medical professionals to learn how to talk to their patients about sexual health?
Well, just really small steps. You know, I didn't have any great vision other than, gosh, you really should know more about this to help your patients. So started with, after the life coaching, I started working with professionals, clinicians who were treating patients for sexual health issues. I thought probably have a lot to learn about what those issues are. What are the interventions? What do people do? How do you treat it? And those are the gynecologists and the urologists that were really treating sexual health side effects. And I learned from them, and we wrote a presentation for oncology nursing because we really believed that nursing is where we needed the awareness raising. With nurses, we thought that the work would be done in the nursing space. Not thinking that it's going to be done necessarily by the oncologists who have, you know, sometimes 7 minutes with their patients, and you're talking about the tumor and the cancer and there's so much to cover in that time, but we thought the care teams, and specifically nursing, it would be more appropriate too. So we wrote a presentation, you know, 2 physicians and a patient, and just kind of went on the road and gave this presentation, and was approached by the Iowa Cancer Consortium, somebody there that said, why don't you write a grant that asks for funding to develop the materials that you say people need? And it was a great idea. You know, I didn't come up with it. It was a great idea. But it was our first step into it. So, you know, for the next 5 years, we had grant funding that developed workshops around the state. We conducted focus groups to learn really what are the barriers to talking about this. Why is there such a communication gap on this? And learned what those barriers are for both patients and providers. Sometimes providers will say, you know, I think my patients would tell me if they had concerns. And I almost laugh at that. You know, no, your patients aren't going to tell you if they have concerns necessarily. You need to leave a space for your patients to tell you that. But anyway, from that grant funding, we were able to develop a comprehensive set of resources for oncology care teams on how to comfortably, knowledgeably, efficiently address sexual health in routine cancer care. And that's really what our mission is for all facilities that treat cancer patients to have that education. But we have moved a little bit into developing education for patients too. So,
yeah. And before we go into that part, maybe describe the current status of the programs that you have for training doctors and nurses.
Sure. So we have 2 online accredited courses. That one of them is a sexual health specialist course, and it was really designed for the advanced practice providers. And navigators too, people who want to know a little deeper about everything sexual health and cancer. In that course, we even have a presentation on how to do a pain-focused pelvic exam. So it's not necessarily for everybody on the care team, but it's for those providers that might be doing that type of work. So how do you evaluate, screen for symptoms, not only just normalize it, but how do you find out what the symptoms are, what do you look for, and then how do you treat possibly what can you treat in the office and what do you need to refer out? And then we have a shorter course for the care team, and that is called the 30-second patient message. So it's what patients need to know. And there, the care teams in that course, they learn 30-second message that's 5 components about sexual health and how common and expected it is, and that it's a quality of life concern, and that you should bring your concerns to your medical team, that they're medical issues, that there are resources to help, and don't wait. So sooner versus later can make a difference on the outcome. It's a 30-second message that these care team members develop themselves. So they learn the components, and then they develop their own message and their conversational tone and what feels right for them. And they learn patient responses, like what some of the reasons that this isn't talked about that we learned in our focus groups is because if you're a patient and I give you a 30-second message, what if you're offended or you're emotional, or what do I do with that? Or what if you ask me a question? What if I don't know the answer? And so it covers, how do I address this without knowing everything? How do I address this efficiently? So those are the 2 courses that we offer that are online and accredited.
And let me just follow. So one of the sort of the bedrock principles, and maybe part of this 5-thing message, is normalizing the conversation. So I mean,
for sure,
that is, you are never going to feel comfortable about having a conversation the first time you have a conversation with the patient. And whether that is in oncology, having conversation about the cancer has progressed and it is treatable but not curable, and the words you say and how you say it and how you normalize conversations. So part of it is the normalization of the conversation about sexual health. I would have to say that you have modeled that pretty well this evening in the ability to, most of us in conversations don't use the words penetrative sex often. And, in the probably 6 times you've used it, it's already become normalized just in this room. And I'm just pointing that out, that normalizing this, which is, anatomy and physiology and part of healthy living, it deserves to be normalized. But I'm just pointing out that normalization of the conversation is probably number 1 for providers in terms of just feeling comfortable about having the conversation.
And one thing that can help normalizing, so it isn't just the words that you say, but the messages that you have. So what do patients see in their waiting rooms? Do they see that sexual health is common and expected? Do they see anything, the signage that is used? We do a lot of resources, clinic resources that we can equip them with, that maybe questions to ask me if I haven't asked you about sexual health. So if I'm a patient waiting for my appointment and I see these are the 10 questions I need to ask my provider if they haven't asked me, or if that's in the exam room, I don't even have to say anything as a patient. I can just point to it and say, can you talk to me about that? That's a way to normalize it, to just leave some space for me as a patient to be able to bring my concerns and questions forward. So the signage is really important. And we also do patient educational materials that can be on display or can be electronic. We do that for that normalization also.
No, that's a good point. Because without that, there's almost this complicity of silence where the doc says, well, I'm not going to bring it up because they haven't brought it up. And the patient's going, well, the doc didn't ask any questions. I guess I won't bring it up. And so since nobody brings it up, it's not discussed. And so normalizing it means you have it as part of the conversation with every visit.
Right. When somebody can give you a 30-second message that this is common and expected, and it's a quality of life concern, they've done so much to open the door for you to bring back a question. You know who to say it to. You know who's comfortable with it. You've been given permission. We also add a brochure that is leave behind, so you take home, which is pretty vanilla in that it just gives kind of at a high level there's a relationship between sexual health and cancer, and here are some of the concerns, and here are things to ask your provider, as a way to plant the seed in the patient's mind that this may be something they want to ask more about, look into. It doesn't have to be addressed at every appointment, but giving the patient the permission to do that really does so much for the provider to not have to do any more than that.
And so you have gone from creating this certified course for providers to take. They can get continuing medical education. They can practice their skills of conversation around the topic. And now the next phase of aftercare is to actually create the direct educational information for the patients.
Yes, so we were never in this space. We were always just training the care teams, but we were asked by a few oncologists last year if we would consider writing a patient course because it could be a good resource for them, because providers feel like they spend when they need to. So when patients do have questions, they don't feel equipped to answer the questions, to have material on hand. So they asked if we would write a patient course. And so we did that. And that course is available on our website, aftercancer.co. That's a patient course. It's free to use. What we ask is that you take the pre-course survey and the post-course survey so that we can learn if this course is helpful in navigating the sexual health challenges. And that's all. It's
When
available
you say
to
it's
anybody.
a course, how long is it?
So there are 14 modules that take 6 to 10 minutes to go through, but you don't have to take all the modules. So the modules are understanding what sexual health is, kind of holistically, what it involves, the sexual response cycle, how it might impact you, those things that matter like desire, loss of interest, body image, how to communicate with a partner, questions to ask your physician, modules like that throughout it. We first divided it into male or female, and 15 to 45 and 46 and above. So you navigate it a little bit like that. So sometimes people in their 60s think about it a little bit differently than somebody who's 25 and is thinking about sexual health also from a reproductive and family planning and trying to figure out how the rest of their life is going to go and where sexual health fits into it. So that's how we organized the course.
And anyone can access it right now. And again, it's aftercancer.co. Yeah.
And when you log on, there's just right above the purple, you'll see the background's purple, but right above that in white, it says new patient course available right here. So you don't have to do anything but go to the home page. Otherwise, you can find it under courses.
And obviously, before you opened it, released it so that anyone can access it like today, you built the course, probably had some volunteers, cancer survivors that agreed to do some of the pre-testing and give you advice and feedback?
Yes, first we conducted focus groups with patients. And the patients gave us the themes, the ideas of what they definitely wanted included in the course. And then those patients also, and the providers as well, they went in and reviewed the course when it was time to do that. So we spent 3 months just in a review process so that we could make the tweaks, the changes, the navigation changes, just everything that would make it an easier course. And I say course, it's really a lot of good information that is mixed media. So it's you're not just reading. There are 30 educational videos from experts on topics like emotional wellness and topics that are important to both male and female organ owners, on topics that the focus group said would be of most interest to them. So that's also a module, these 30 different videos.
And if a patient goes through the course, is there opportunity for a deeper dive into particular topics through either through the website or resources that are available for going deeper into the topic?
Well, so deeper in the topic would be specific modules on like desire, because that's a big one. Specific modules on body image, specific on vaginal health and menopause and erectile dysfunction. And so there are some specific big topics that maybe there's a little bit more time spent on that go to sexual function and the sexual response cycle, so how easily it is to be aroused, to have orgasm, to be able to feel like being close with someone like that. So we do deeper dive there, and then the deeper insights really are through those expert videos from clinicians around the country on specific topics.
So many patients may want to talk to a provider that is more experienced in helping with sexual health. Is there anything that you provide, a list of providers that are resources for the medical discussion and or treatment of sexual health issues?
It's a good question. I feel like that's a bit of a gap. So the way we probably answer that is we do have on the website a partnership program. So we list people that have gone through the training. We were even asked to do that from like insurance companies who wanted to be able to point their patients to providers that had been trained in sexual health. There is under patient resources, there is a PDF that opens up to lots of national organizations that can be good resources for patients. And I do see now that we've dipped our toe into providing patient resources directly as opposed to just education to the providers, I do see that there will be more opportunity for us to expand that, to do more for the patient directly. So we're open to listening to all of those ideas for what we do and for future courses.
Yeah. Correct me if I'm wrong, but I think when you started doing the provider information and you sought out experts, and as you mentioned, it started off with gynecology and with urology. Were most of those at the university?
So when we started out, university was one place because one of the co-facilitators of the work was the medical director of the Menopause and Sexual Health Clinic at the University of Iowa, and the urologist was also Dr. Brad Erickson from the University of Iowa. So we did start with Iowa, but the grant that we received was for all of Iowa. So like we came here and did a workshop at Unity Point. So we went around the state and made sure that we were partnering with all of those groups that, as many of the 99 counties as we could.
And did you have a good buy-in from the different medical centers, cancer centers around the state?
Yes. People were hungry for any knowledge on how to help patients. So sometimes people just wanted to be a bit of a champion, just a sexual health champion. I want to if my patients need this, I want to know something more so that I can be a better resource for my patients. And in some cases, people really wanted more process around it too. So what can I give them? What do I say? What can I give them? And working with leadership, then we would do workshops for them where they went through role play scenarios, so oncology role play scenarios with simulated patients. So they'd be in the hot seat, so to speak, and a patient would be here and they'd give their 30-second message and the patient would respond and they'd have to figure out their exit strategy to transition back to work. So it was a real live oncology scenarios that they could imagine, then implementing that into their routine care.
So obviously you had your own personal experience and you had done a lot of research. As you started doing the focus groups with patients, what surprising things did you learn that you were different than your own experience? Yeah,
one thing sticks out. Patients said so there are lots of reasons why we don't bring this up as patients. So we also are expecting our care team to guide us on what we should care about, right? They tell us what to eat. They tell us what we can and can't do for activities. And so when this isn't brought up at all, we assume as patients that it's not something we should even be thinking about. So we take guidance from them. But the thing that surprised me most, patients said that I don't talk about this because I don't know if I have the right terminology to talk about it. And there is a fear of being negatively judged as being stupid or really caring about the wrong thing. You have cancer, remember? There's a fear of that and appearing too greedy. That part I got, the greedy part. the not having the terminology. They don't want to say down there. They don't know exactly where the pain is. And that, I say that wasn't my concern, but it was a problem for me to explain that I think he's hitting a wall. And he said, I'm not even inside of her. Well, how do you reconcile that? Well, there's no camera. So how do you reconcile that? All I can say is what I'm feeling. I feel like you're hitting a wall. Well, if you don't know the right words, that was easy because it was wall. That's the word I had to use. But nobody wants to not use appropriate terminology. Mm-hmm. And that is a reason why patients will not say anything at all.
Mm-hmm. Yeah. We're going to open up for questions. So we've got a live studio audience. So now that we've normalized talking about this, feel free. You will get the first chance to ask a question. If you're at home watching us virtually, you can put your questions into the comments section of the software that you're using.
Okay. Yeah. My question has to do with sexual health on both sides of the equation for cancer. It's understandable how important it is in cancer recovery. What about as a cancer preventative, good sexual health? It seems like it's just a healthy pursuit, and if you're healthy in that aspect of your life, you'll be less likely to get cancer.
Wow, that's interesting. I've never thought about it exactly like that. But what I was going to say, when you first started with the prehabilitation idea, is that we do really encourage this conversation not to happen in survivorship. We encourage it to happen at the diagnosis because there are some prehabilitation things, exercises, especially with, like the prostate cancer has been doing this for a long time, where there are exercises that males can do before their surgery to actually lower their anxiety about it, and be compliant on what needs to be done in their recovery. So that whole prehabilitation term is something we highly encourage cancer centers to do for all cancer patients that are going through, breast cancer surgery, just kind of like patient-centered care, like we used to do the Lamaze. I think that's a wise thing to do for patients from a prehabilitation standpoint. In terms of what your sexual health is like before cancer, I would say that is something that's important to understand. Like if a patient were to say, is my sexual health going to be better or worse after cancer? Well, I don't know. What is it now? Because it's probably not getting better. Your communication isn't going to get better. Life is about to change. Everything is going to be heavy. So things don't typically improve without work. So one of the things that we would suggest to care teams is, if people are concerned about sexual health early on, to have a baseline of how things were before they had cancer. So from a function standpoint, you could at least address how things have changed. Always, though, I would say, I don't know if I've ever known someone that wouldn't have benefited from counseling, from couples therapy, that goes through this, that goes through cancer. It can be about sexual health, or it can be just about well-being. Cancer changes so much about who we are and how we communicate with each other and how we connect with each other, that counseling is just an important piece, that we recommend that cancer centers have a direct line to therapists, mental health therapists, for cancer patients. So we're working with the hub to be a source for cancer centers to contact the hub and for patients to contact the hub to find a therapist that is used to talking to prostate cancer patients, that will take insurance that they have, that are available on the weekends, that will do a video call, that type of thing. That's how important I think counseling is with cancer. And number 2 is probably pelvic floor therapy. I just want to get that plug in for
Yeah.
pelvic floor therapy.
And we have had pelvic floor therapists on our show, so they are physical therapists who then are subspecialize in the pelvic floor, and very, very important for both men and women going through any sort of pelvic treatment or treatment that involves the pelvis. I mean, it can be used in other situations, whether neurologic disorders or muscular disorders, but clearly in the world of cancer, focusing on the pelvis. Yes, George.
Just
another
a
question.
follow-up question on sexual health and the pecking order, the significance of sexual health. I could see where somebody freshly diagnosed with cancer would say or think, I'm not going to worry about sexual health. I'll put that off 6 months, a year, whatever the case might be. But they don't understand the significance of good sexual health. And the question then becomes, do the practitioners, does the industry, is it really appreciated as much as it should be?
Yeah, actually, you hit on something that's really very common, that I'll deal with that next year. I am going to deal with the cancer this year. And that works as long as your relationship then doesn't change. If you could just freeze that in time, if nothing impacts that. And that's highly unlikely. Also, in situations where radiation is involved, you can't wait until next year. The damage is irreversible. I waited 5 to 6 months to get treated, and when I was told, what I was told is, I'm sorry, but you waited too long, when I hadn't waited at all. You can't wait with radiation damage. You can wait with some, but what sexual health, the problems associated with sexual health tend to be persistent and don't cure themselves on their own. They need attention. So waiting until next year, which is a common thought, by waiting even 6 months, functionally, I couldn't have penetrative sex, but it also did so much damage in that 2 years to my relationship. We had gradually just grown apart, that we separated for 3.5 years at that point. There was just no connection, no intimacy between the two of us. So that's the problem with waiting, is that your relationship doesn't just stay frozen in time to wait until you want to pay attention to it again.
And you raise a very good point, and that is the idea of that time will heal. And so most people who have some sort of a procedure, there's sort of these limitations you have, and this general, just give it some time, let it heal, it'll get better with time. And you're right, there'd be no way that the average person would have any idea that things get worse after radiation with time, and things don't get better. They get worse in terms of the radiation fibrosis. So with radiation, while you're going through the radiation, is more inflammation. And yes, the inflammation gets better with time, but the real problem becomes the fibrosis, the scarring, and that's something that gets worse with time. And it's just not intuitive that people would understand that. It should be knowledge that every oncologist has.
Yes.
But it would be not knowledge that most patients would intuitively have.
One of the pieces of that 30-second message, and it's the last point, we teach to say, I understand you probably don't care about this right now. I get it. I wouldn't either. It's probably not important right now in your life. But studies show addressing issues sooner versus later makes a difference on the outcome, or whether, the chances of them being resolved. We teach that because we want providers to acknowledge where the patient is in the moment. You might not care about it right now. You might not be sexually active right now. It might not matter. You have a right to know, though, that there is a relationship between sexual health and cancer, and that the impact of your treatment can damage what you consider good sexual health. So you knowing that information will at least give you that information to get help, to notice changes, to bring back questions, to inquire as you're curious about what those issues would be, maybe even do a little research on your own. Just normalizing that, just giving you that much information, leaves it then to the patient to determine how much more of that information do they want to have.
Next question. Yes.
I strongly agree with Dr. Deming about your ability to talk so comfortably, so candidly, so able to easily disclose about your own experience with sexual health. You are gifted in that regard.
Oh, thank you.
I happen to be a counselor for many years, mostly in public schools. And I taught sex ed to 4th, 5th, and 6th graders. And the word that comes to my mind is desensitization.
Mm-hmm.
I mean, I was uncomfortable using that vocabulary to begin with, but the more I did it, I mean, year after year after year, it's like,
Right.
oh, yeah, there's that word again. And the kids, I could see them being very uncomfortable in the beginning, but that eased in time. So as I listen to you talk, I'm thinking, oh, I would love to have had you as a co-facilitator. And then the last comment I have is just that the whole issue of sexuality is such a gift that we've been given. And our society has kind of just destroyed that. We laugh about sex. It can be a power thing. It can be, just so many things. But what you're doing and the manner in which you're talking about it and treating it is such a healthy thing to be doing. So thank you. Thank you for that.
Appreciate the comment.
Yeah.
Thank you.
Anal was a tough word. Anal cancer. I remember my kids were junior high age, early high school, and they chose not to be honest about what the cancer was because, they asked, can we call it something else? And, when you think about it, how often do you use that term, anal? Never, I bet, never. We never use that term. I wanted to have something, sexy like breast cancer. We use the word breast, that's okay. And they wanted to call it colorectal cancer. They asked, can we call it something else? And I said no. You can call it asshole cancer, but they said that, Mom, you don't understand. And I was kidding.
So maybe just, Angelina, you go next.
Well, I meet with a group of other survivors, and those are still going through it. And as this common theme and discussion, and asking each other, how was it with breast cancer? Because that's what I had, and some had the mastectomy, some didn't, and how it was with their partner.
Yeah.
And how the comparing notes of, it was like, oh gosh, I thought I was the only one that filled that. Because you do, with the radiation, you feel the scarring and everything. So you find sometimes the sensation of what you had before the cancer, before the treatment, is different. And having that dialogue. So in any of those modules talk about that for breast
Yeah,
cancers?
I'm really glad you brought that up. So one of the things that the first module talks about is what is sexual health? And we're not talking about sexual function or penetrative sex. That's not what this is all about. I mean, it's not that it doesn't include it. It's really more about the sexual wholeness. So the body image, it's about sensitivity. It's about why neuropathy would be difficult in sexual play. And you think about how important is it for you to use your fingers, to use your hands to touch in sexual play and any kind of sexual activity. Of course that's important. So neuropathy would be a big deal. But until you think about it holistically like that it involves more than a penis and can that penis get erect enough to have penetrative sex? It involves more than that. It involves how I feel about myself. It involves the hot flashes or the nausea or the mucositis, how sexy do you feel with sores in your mouth? When we think of it that way, and care teams, when they think of it that way, they think, oh yeah, of course people need some assistance here. Hadn't thought about that. And that's what I think really what the workshops and the courses are more helpful than anything at doing that, to think about sexual health far more than just sexual function. And sensitivity, the skin changes. What I noticed too is that what used to feel good in the genital area hurt. That hurts. You can't touch me like that. That hurts. It's a whole new educating of how to give and receive pleasure that you had no idea that would be part of this recovery from cancer. So having care team members understand that everything has changed, physically and emotionally, helps them.
Gary.
I'm curious about insurance, and do they recognize, these issues, and do most insurance carriers cover this? Not only insurance, but also Medicare?
No, no, and no. And it's so too bad that, the kind of games you play with what could possibly be something that insurance would cover. Adjustment disorder is often a code that people would use that needed to help patients with adjusting, and sexual health has so much to do with overall well-being. Those two things are kind of synonymous in many cases. So adjustment disorder would be something that would, but otherwise, no. So now a provider, so an APP, so a nurse practitioner or a PA or an oncologist, they, of course, would have coding to be able to speak to a patient about this. But in those days, this not being normalized for the patient, it just wasn't brought up at all. So there was nothing there. I think people have a better awareness now, not just because of after cancer, but I think there is more of an awareness now that there's a gap here. There's a communication gap. And our patients need resources on this topic, and we need to have something for them. We're seeing more and more of that, which is, great. I am shocked that it's 2026 and this is just happening. I thought that, oh, wow, once we do this next year, everybody's going to be good. And of course, it didn't work like that at all.
Other questions? Any questions online? Well, let me ask you, you brought up your family and the 4 children who were teenagers.
Mm-hmm.
And how do you think your cancer journey, and not just the sexual health
Right.
part, affected your children? And they must be now all young adults.
They are.
And are you a grandma yet?
Yes.
Okay, you are. Okay,
Yes, yes.
So, yeah.
Just once.
Okay.
Yeah, just a little tiny one.
Well, good for you. But, and of course, each of your children is different, but maybe reflect a little bit on how your cancer journey affected the children and what the adults they became.
I'm embarrassed to say I'm not 100% sure
Okay.
about that, but
Yeah.
I think I'm going to
And
ask
maybe
that question.
Maybe you don't have to, respond on camera.
Well, right. I think they're better for it. I think I'm better for it. I think being vulnerable about your life and your challenges, and then attacking it, in whatever clumsy way that you attack it, is good. I think that my kids probably learned more than they wanted to know. They, were afraid somebody might ask mom a question. She might tell too much.
And she'll use a word like anal.
Yeah, right. There probably was some fear there. I think now I'm going to ask the question though. What was that experience for how they feel it may have shaped them? I'm not 100% sure.
Okay. Okay. Well, it's been great having you on again. So our guest has been Erin Sullivan Wagner. She is the executive director of the not-for-profit After Cancer, and you can learn more about it and actually utilize the tools for cancer survivors dealing with sexual health issues at aftercancer.co. And thank you for what you've done to take the wisdom you've gained from your own journey and use it to create something to help others.
Thank you very much. Thanks for having me.
If you know someone that would benefit by watching this program, good news, it's going to be available on demand for anyone to watch whenever they would like, beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. Thanks for joining us. Please join again next week. Thanks, everyone.